with all due respect.
Hey, we're Josh Ortegon and Gray Achille, and this is With All Due Respect, the show where we keep it real about health, fitness, and performance. From weight loss to sports development, we're covering the conversations that matter.
Follow us on Instagram at WaterXPod, WADR, and visit PhenomBrand.com, PHNM, for performance gear and training programs built for real results. Let's get into it.
All right, guys, we are live. I think we're live. Episode of 106, back with Mike. And guys, I'm going to tell this. I'm going to say this to Mike. Mike's he's humble, human. The number of people you've been able to help through this podcast, I don't go a week without somebody saying something. I'm being dead serious, Mike.
That's cool.
I don't go a week without somebody, hey, who's that guy on your podcast? How do I get in touch with him?
Mm-hmm.
To good friends of mine that's a dentist, to family members, to people that we still coach that would be like, hey, I need to get in touch with Mike. I was like, we can drive. She's like, I'll drive. I'll drive. Just your overall different look at care. It's refreshing. The number of times we can have you on and just dominate all of your time, the better. I know you're busy. Can we, and guys, if you're seeing the title of this episode, our attempt is to have a conversation on PCOS. Okay. If it ever ends up going south and all of a sudden we're having a conversation on something else, that's just who we are. Okay.
I'm going to start keeping a tally system for every time we go off target.
Yeah.
We're going to do like a burpee.
Oh my God. Yeah. That'd be horrible. Mike, can we start off this episode by you doing another intro of who you are and what you do and how they can find you? Because I had to save in the notes in my phone how to get in touch with Mike.
Mm-hmm.
So I send people how to get in touch with here, right here, boom. So let them know who you are, where you work, what you do, how they can find you, and then we're going to go.
Yeah.
Mm-hmm.
So I'm currently PA in primary care. Prior to becoming a PA, I also did a master's in exercise physiology, one of the U.S. Olympic training sites with Meg and Mike Stone. Spent some time up there, worked with all kinds of different sports, all kinds of different teams and athletes, everybody from sixth graders coming up to people that were in the Olympics or qualifying for the Olympics. Prior to that, I also did undergrad in human nutrition or nutrition and human performance, and then spent a long time doing 5 different internships in multiple strength and conditioning roles. From Exos, which is athletes performance, and they've worked with people. I don't know if people know this. I actually interned with Josh back in the day, 2014, I think it was, and then also spent time with the University of South Carolina back when they had back-to-back College World Series championships. So that was a cool time to be with them. So kind of done a lot of different things in the health, performance, nutrition world, but now both of those lenses intersect. So medicine and performance. And so I try to have a very different take on medicine compared to most people, where rather than just talk about drugs and surgery, all the things that we learned in school, I talk heavily with patients about nutritional biochemistry, the intersection between immunology and nutrition, the intersection between sleep, lifestyle, activity, stress, all of these different things. And I probably spend less than 10% of my time with most patients talking about drugs, because the vast majority of time I try to get to those last. They do help. There are times for them. I'm not anti-pharmaceutical, but I think there's many, many other tools in the toolbox that, number one, we never get taught in school. So pretty much the vast majority of things that we'll talk about on this podcast, most of them were acquired outside of my time in the classroom through either additional training or from personal self-study of things and some resources that I've kind of developed along the way. And then also from the fact that there's a need for it. And so as you go through school, you pick up all the things that you should know, but then you get into clinical practice and you apply those and think, oh, this really doesn't work as well as I thought it was going to. And then that's where we're going to have to fill in the rest of the equation. So that's kind of who I am, how we got to this point. You can listen to all the other podcast episodes that I've been on in the past for all the other topics that we've covered, and that may fill in more of the gaps.
Yeah, absolutely. Thanks. And the reason I want to start with this is we're so familiar with you. I've known you for 15 years, right? 14 years. We have you on all the time. And I just have people that reach out to me all the time, Mike, and be like, hey, where is that guy? Is he in Columbia? Where can I see him? And I'm like, okay, let's just get it off and we'll put it in the notes that people that can come see you. I always tell people, and they always say this, I want to talk to Mike. And I like the fact that we're not leading with medication first. I
Mhm.
actually have a client who is contacting about bringing her husband because they want to make sure, and this is probably a touchy thing when you're dealing with people with multiple medicine. She goes, we just want to bring everything to Mike and sit down that we're doing and make sure like they have 3 different doctors with all these different medications. They're just like, we just need to have a one focus point, a person to talk to because we're
Mhm.
getting input from all 3 different people on all 3 different things. We just need to sit down with somebody to make sure that like we're taking care of all the things we need to take care of because we're on so many different medications. Do we even need all this? Right. And I know that's touchy because you can't go against other but it's a good place to start and a good
Mhm.
conversation to start. So Gray, let us know why you hit us up and we're like, we need to have a PCOS podcast.
Well, I think the major thing was that the actual name of PCOS is now changed to it's POMS.
PMOS.
Yeah, so I really wanted to talk about like why the name change, what this will do for people that are diagnosed already with PCOS, who this opens up a diagnosis for people that have not yet been diagnosed, like why did it change everything? But then also with our fertility podcast series that we did at the beginning of the year, we had a hard time finding someone to come on and really just nail down PCOS. Like I got in touch with a few people, but it just didn't work out. So some people kind of briefly talked about it, but I was like, we haven't done a full episode on PCOS. And I've now worked with women, like at least 5 or 6 women that have had PCOS. It's a very common diagnosis, I feel like. And I think sometimes it can be kind of loosely thrown around like, oh, I think I have PCOS, or my doctor told me I had PCOS, but there hasn't been like formal testing done or whatever. So, yeah, I think it would just be an interesting place to really talk about, especially with it now being at the forefront of a lot of people's feed.
Mhm.
Yeah,
I
that's
would
it,
say we
Josh.
start with no, I'm going to say, what does it stand? Why did it go from PCOS to PMOS?
PMOS. Yeah.
What is it? What is it? What are the symptoms? How can somebody look out for it? And why is there always confusion? Because as a dude, I have heard of it. I have had women that we've coached that have said, I'm going to get checked for it. They don't have it. They do have it. I do feel, Gray, I will agree. I do feel like it's kind of like the people that say they have a gluten intolerance. Like, I'm allergic to wheat gluten.
Yeah.
Well, how do you know you're allergic to gluten? Well, because when I eat 8 Eggo waffles, my stomach hurts. Right. Well,
Well, the symptoms of PCOS there's a ton of them, first of all, and secondly, it's very like a lot of them are very common just in life in general, right? So like I had an esthetician one time ask me if I had PCOS just because I have hormonal acne. Okay, but that's not always like, yes, it's a symptom of PCOS, but it's also just a normal symptom of not having PCOS. So then people can get in their heads, or women can get in their heads like, well, maybe I have PCOS, but they don't fall under the rest of the symptomology. So again, yeah, I think let's just start with what is PCOS and why did it change to PMOS?
People used to think of it as just polycystic ovarian syndrome, PCOS. So it was basically if you had lots of cysts on your ovaries, people were diagnosed as having PCOS.
Right.
The name was recently changed to polyendocrine metabolic ovarian syndrome, meaning that there's multiple components now enveloped in this whole diagnosis, not just cysts on the ovaries. So, in order for somebody to get diagnosed with PCOS, and let's step back 1 second. If you're a dude and you've made it this far on the podcast, thumbs up to you, because most people would have just clicked off and said, this is not for me. I'm not a female. The reason why this is relevant to you is PCOS is the number 1 endocrine disorder in females and also the number 1 cause of infertility in premenopausal females. So if you're married to somebody, if you're dating somebody, if you have people who are coming to you that are confiding in you on, oh, I'm having these symptoms, it's good to generally be aware of, because you're going to come in contact with these women. I guarantee it. And you're going to start to notice when we talk about like the signs and symptoms, you'll start to notice these on people and put together the signs and symptoms. We'll talk about why these people often get missed with labs, with the standard labs that are run. And if you're generally aware of these things and you work in some sort of health, fitness, nutrition capacity, you can make a huge difference in a female's life over the course of her childbearing years if you know these things. So that's kind of step one to know. So the reason why it changed from PCOS to PMOS is due to the fact that now we're understanding there's more research that there's other pieces besides just cysts. In order to get diagnosed with PCOS, you have to have 2 out of the 3 following criteria. It's called the Rotterdam Criteria. You have to have menstrual abnormalities, meaning that you have really long cycles, you skip cycles, they're not consistent. And you probably, some women are not going to measure this, but you do not ovulate. And that's why there's a huge fertility component. So these women have differences in their cycles and they do not actually ovulate. The second piece is you have to have androgenic symptoms, meaning symptoms that are commonly seen with high androgen hormones like testosterone, DHT, which is a metabolite of testosterone, or DHEA, which is a precursor to testosterone. Those symptoms will look like dark facial hair. They will look like thick, kind of velvety looking skin on the back of the neck, in the armpits. That's a lot of times due to insulin resistance. It'll also be due to sometimes even like changes in the voice, deepening of the voice. You'll also see things, you'll also see kind of delayed things, but sometimes it'll show up as like mood changes, or it'll show up as additional insulin resistance changes because of these high androgen hormones. And the third piece to this is you have to have imaging confirming multiple cysts, at least 12 on the ovaries, in order to be diagnosed with PMOS. So you have to have 2 out of the 3 of those. So people can have normal imaging, so they can have no cysts on the ovaries. But if they have the androgenic symptoms and they have what's called anovulation, the lack of menstruation and the differences in their menstrual cycles, they skip cycles or they're really prolonged, that's diagnostic for PCOS alone, independent of the imaging. If you also have the imaging findings and you don't have the androgenic symptoms, but you have the menstrual abnormalities, that's also PCOS. So don't let someone tell you, if your imaging's normal, that you don't have PCOS or PMOS. We'll use those interchangeably throughout the podcast. So that's the first thing. But also, if you have 1 cyst on your ovary, this is not PCOS. That's the other thing. So you should keep in mind, there is a diagnostic criteria with the number of cysts and also the size of them. But in general, it's going to be described on ultrasound is how you find this. On ultrasound, it's going to be described as a string of pearls. So it's multiple cysts, typically in a line. But they were described to us in school like a chocolate chip cookie. And so that's what it looks like on the ultrasound. You're going to have these dark and then these light bits where the cysts are, and it looks like the chocolate chips in the chocolate chip cookie. So that's your criteria for actually diagnosing it. And then we can kind of get into like all the hormonal pieces and how that affects blood sugar, the labs, treatment, all those things. But keep in mind, you always have to have 2 out of the 3 of those. You can have 1, but that's not diagnostic of it. So I'm always careful to make sure that people know you can get slapped with a label very early on, and that can become part of who you are. So it's very important to understand yes or no, I do or don't have it. And if I do have it, great. Then let's talk about what to do.
The androgen changes.
So the androgen changes typically are going to be mediated by a couple different things. There is a genetic component. We do know that. The secondary thing is there's often an insulin resistant component. And so with insulin resistance, we're finding in the newer literature, it was just published in, I think, 2026 now, that with insulin resistance, you're going to find that those in PCOS are genetically more insulin resistant. They tend to also have, when insulin goes up, you'll see a lowering of sex hormone binding globulin. And so because of that, you will have more free testosterone in circulation. And then there's also newer data showing that these women have enhanced androgen receptor sensitivity and density, meaning that if you run testosterone, a DHT, and a DHEA in a female, so DHEA is at the top, testosterone is in the middle, DHT is at the bottom. That's kind of with multiple other things in there, but that's kind of the big pathway. If you check all those hormones and they're all normal, somebody says, oh, I don't have PCOS. That's not true, because you can have a normal testosterone, but if you have an elevated free or an elevated receptor sensitivity, the normal circulating amount binds with a much higher affinity to the receptor. That's
Well, there's a genetic component here.
Yes, absolutely.
Okay.
And because of that genetic component, these women should understand that over the course of the rest of their life, there are things that they need to consistently do in order to keep this in check. It's not just a one and done thing.
Mm-hmm. Yeah. So that's it. I mean, that's a great segue into like how to actually manage, because I know that was, I think I included that in my text too, is how to actually manage it. Because I think that's another thing. It's, I don't know how to properly manage it without just going to see my doctor and them telling me I need the imaging done. And I don't know, is there a medication for PCOS, or is it really just lifestyle management? Yeah.
So it's two things.
It's metformin.
That's
Is
one.
that one of them? Yeah. Yeah.
And do you know the other one? It's what we put every female on when she ever has any problem and we don't know what to do with
Birth
her
control.
from an OB standpoint.
Oh yeah, birth control.
Yeah, there we go.
Duh.
Yeah,
Duh.
yeah. I was gonna say that's the go-to, right?
Yeah.
Why birth control? Why are they?
So in PCOS, you have these. We talked about a couple of these hormone cascades, but coming out of the brain, you have this hormone GnRH, and GnRH basically will go down and stimulate LH and FSH, and then because of that, those will then stimulate ovulation. Well, the problem is in PCOS, we actually now know from the literature that they have abnormal GRH pulsatile nature. So they have this abnormal increased excretion of GnRH. And so that's what throws off the whole cycle. And so that's what gets the cycle longer and shorter. And so because of that, we will give things like birth control, conventional medicine will, and that basically will override the signals coming out of the brain. And so you're basically telling the body, I don't care what the brain's telling the independent ovaries. We basically are going to give you something orally that's going to force you to stay on a certain cycle in the hopes that it regulates your cycle. Sometimes it does.
Mm-hmm. And then so talking about the management piece of it then, because we know birth control is a management piece from your doctor. Metformin can be a management piece as well. Outside of those two things, if somebody is like, okay, yeah, got that on check, I want to manage it through lifestyle. Because I remember we had a list that you created that we would send to clients, and it looks a little bit different than what we would normally have them do.
Mm-hmm.
So like reduction in fruit sometimes, reduction in snacks, like it's 3 meals instead of snacks. So can you kind of talk about the bigger picture maybe with lifestyle management, and then maybe those like smaller nitty-gritty things that can help?
Yeah. So I usually with PCOS, the one thing you got to keep in mind is, and I'm just pulling up the list here that I put together just to reference back on it. So with PCOS, it's important that we really don't forget about the genetic component with this, in that there's nothing wrong with the conventional management in terms of the birth control, the metformin. Nothing wrong with that, because sometimes insurance pays for it, and that's what you got to do. But from the lifestyle perspective, most of these things are going to be free. Number one, and number two. Wow, long day. Number two, they're going to be side effect free. So that's kind of the other piece to this. So the first piece would be from a nutrition standpoint, because of the insulin resistance that we know is there all the time. And we should also talk about, there's other data showing that women with PCOS have higher circulating levels of inflammatory markers and inflammatory cytokines all the time. That's just independently, genetically, they're already there. So we'll talk about the implications of that with treatment. But the reason why that's relevant is because of the increased inflammatory markers and cytokines, those will drive insulin resistance. That's part of the reason why someone becomes insulin resistant with PCOS. Because of that genetic predisposition, these individuals will not handle high carbohydrate meals well. They will definitely not handle high carbohydrate snacks well, because they don't have the balance of fiber and protein. So that's kind of the first key takeaway. If you have PCOS, number one, you've got to regulate your blood sugar really well, meaning that when you eat a meal, you don't have to track it with a continuous glucose monitor. But there's 3 options when anybody eats a meal. The first one is what we want everybody to encounter, meaning that you eat the meal. The only thing you notice is now that you get full. So you don't feel anything else. Option number 2 is you eat the meal and you get really sleepy. You have now eaten way too many carbs. But the probable option, there's another kind of GI mediated piece, but it's probable that you just ate too many carbs. The third option is you were really low in energy. You ate the meal and then you got more energetic. Your blood sugar was too low. So ideally, we all want to be number 1. A lot of PCOS patients will be number 2. Similarly, a lot of diabetics will feel number 2. They'll eat and then they'll say, oh man, I just want to take a nap. A lot of people experience this between 2 and 3 o'clock in the afternoon. Many times it's blood sugar. So that's kind of the one piece to this puzzle, that if you're experiencing that after meals, you likely need to reduce the carbohydrate intake in each individual meal. And you should also play around with when you're having carbohydrates during the day. Some of these individuals will not feel good eating carbohydrates throughout the day. They'll be sluggish. They'll have brain fog. They'll feel like they can't focus. And so they need to push more of their carbs towards the evening. Josh, you and I were talking about on an older podcast. I remember the guy's name. You remember John Kiefer? He's the guy that came up with carbohydrate backloading.
Yeah.
So
Yes.
right, Kiefer. So it came to
Yes.
me at like 2 a.m. one morning, and I was like, I remember.
Yes.
So these sort of patients may find that if they carb backload a little bit, they can use that increased serotonin in the brain from the carbohydrates to enhance sleep, but it doesn't detract from their cognitive abilities during the day. Similarly, if they're going to work out in the afternoon, they'll be most insulin sensitive after their workout. And then a lot of those carbohydrates will be uptaken into the muscle. So that's kind of the other thing. You probably want to put more of your carbs around that workout window, pre and post workout, to get the most benefit because you are already genetically insulin resistant because of the inflammation piece that we talked about. So that's one of the key takeaways there. Carbohydrate timing, and then carbohydrate spacing throughout the day. I don't know what's best for everybody. Some people feel really good with carbs at breakfast. Other people feel terrible throughout the day if they eat a carby breakfast. You will have to experiment. There is no test that will tell me what you should and should not do. Your body will tell you what you should do. And that's kind of one of the key takeaways.
Okay. Is that a general takeaway for people, or is that just a general takeaway for PCOS?
Oh, absolutely for everybody.
Okay. I am not a high carby morning first meal person. I higher carbs, lower fat meal. I find blood sugar irregularities throughout the day. If I do more, and you guys got to realize the amount of food. Me and Mike were talking about food intake on our text yesterday, and Mike was throwing out some absolutely ridiculous caloric intake numbers, and I was just like, "That's ridiculous." But if I'm not 25 to 30, 25-ish grams of fats in the morning with moderate carbohydrates and protein, I will experience lower blood sugar throughout the day. So I need fats and carbs first thing in the morning to slow digest. And then around my workouts, I can load carbs. And then, Mike, and this is, we'll get to just on my brain, because this is actually a conversation I was having literally today. I used to do my third highest carbohydrate meal 2 hours before bed. That was your recommendation to me, Mike, 10 years ago. And I've still done it off and on within my life for the purpose of better sleep. And it does. I would do oatmeal, big amount of oatmeal and fruit with low protein, with low fat at night. And anecdotal, but I'm just telling you, it made a difference in my sleepiness throughout. So, but if I do high carbs, low fat, moderate protein first thing in the morning, I have a harder time managing blood sugar throughout the day. I'm hungrier throughout the day, which can be good for increased appetite throughout the day, right? Because my blood sugar starts getting low and I'm just mashing food. Like, we've all had that low blood sugar food mash, right? Like, that low blood sugar food mash is like, I can do 1,500 calories in 30 minutes on a low blood sugar mash. But it correlates to what you're saying to women with PCOS, where they become so sensitive to carbs. So my next question is, are they sensitive to carbohydrates, Mike, or are they sensitive to just really crappy carbs like all of us? Is this truly a carb issue of rice, potatoes, oats, sweet potatoes, high starch vegetables, or is this so many people eat crappy carbs and those are the problem, or is it a combination of two? Does that understand? Do you understand what I'm saying? Okay.
If someone is eating a balanced whole food intake, meaning that all of your meals throughout the day are composed of carbs, fat, and protein, all of your meals throughout the day are just meals and you're not snacking, all of your meals are composed of mainly whole foods, primarily single ingredient foods that are grown, harvested in the same sort of fashion that they were created in, meaning you're eating potatoes, you're not eating French fries, you're eating cheese, you're not eating queso, like those sort of things. Those are the sort of people that it's more than likely that the genetic insulin resistance piece, if they're still getting sleepy after the meals, is probably the issue. But I would still encourage that individual to play around with the carbs throughout the day and see if there's any correlation. We also know from newer data that you can slap a continuous glucose monitor on somebody and you see a really high intra-individual meal glucose variability. They did this super cool study where they fed people, I can't remember if it was genetic twins or if they took the same person and brought them back. But they basically saw when you fed the same amount of ice cream to two different individuals, they basically had two totally different blood sugar responses. One person cruised right along at 100, the other person went up to 250. And so these were the same people across the age spectrum, health spectrum. It wasn't like one had diabetes and the other didn't. And so a lot of that will be related to the environment of the meal. And a lot of that will be related to what's happening before and after the meal. So we know from the literature, if somebody goes on a 10-minute walk and they activate the soleus, which is kind of this big like sponge in the calf muscle complex, that absorbs a huge amount of carbohydrates, and you will shunt a large amount of those carbohydrates out of the blood just from activating that. We also know if you recreate that data and have somebody just do calf raises, just activate that soleus muscle, it also pushes a large amount of blood sugar out of the bloodstream. So that's where I would say that person could probably experiment, but they may find that activity alone offsets the effects of those carbohydrates because you're turning on a different type of glucose transporter, and that's only turned on with activity. So GLUT1 and GLUT2 are on all the time, but GLUT4 only turns on with activity. So if you have PCOS, activity needs to be part of your life. Like it just has to be for the rest of your life. Yeah. You have to be eating probably less carbohydrates than all your friends, and you have to be more active than a large majority of your friends. That is just going to have to be part of the puzzle. Sometimes we don't like the rules, but our body's always going to play by the rules, even if we don't like them.
Mm-hmm. Yeah, well, I think that's like a common thing that you have to talk about with, or I guess yourself or like with clients too, is just like where the carbohydrates piece fits in for most people. Like, cause I know when you guys are talking about your carbohydrates, I have to have a high carb breakfast or I'm a bitch if
Really?
I don't have carbs.
You. Okay, so
well, I walk in the morning and then I go work out. So like if I don't have a decently high carbohydrate breakfast, like I feel like trash after because I get it. Like
I could literally do no carbs.
I
could do no carbohydrates for breakfast. I could do literally 4 eggs.
That's what I do for lunch.
A scoop of cottage cheese and thing of peanut butter and be completely in little fruit, maybe like not a lot high, but I could literally do no carbs for breakfast and be fine. But when I'm trying to hit carbohydrates around training and lifting, I can't do that. I have to do something. I just add fat to the meal.
Yeah.
And I can do it.
I think it's always so interesting to me how people's bodies, minds, brains all work just differently because we all just, I mean, obviously we have different things that go on in the day that are going to make things work differently for us, but just the difference in how it makes us feel, I think is always
Are you guys hungry first thing in the morning?
Starving.
Are you? Absolutely not. No interest in eating first thing in the morning. It takes me about an hour.
Yeah, I'm starving.
I'll do a small
6 a.m.
Probably it takes me about an hour and a half. No, I'm lying to you. It takes me about an hour and a half. It takes me an hour and a half to generally create an appetite too. But you know what I do that's weird too, Mike, is I'll usually eat 8:30 in the morning breakfast and eat at my last meal at 8:30. I do the 12-hour fasting.
Mm-hmm.
So when people are actually like, do you intermittent fast? I said, yeah, 12 and 12. Like, you know what I'm saying? Like I eat from 8:30 in the morning to 8:30 at night. And then I don't eat again. I go to bed at 10:30. It's my 2-hour window and I sleep. And I don't listen. I've done it for so long. I don't know if it would be different for me now. I don't know if I changed that, if it would be different. It's just the routine that I can, and I can get 3,500 calories in 12 hours, right?
Mm-hmm.
I can do that. I don't know if I changed that, if my digestion would be different, if my body would be different. I know and Mike, can I ask this? I'm nauseous in the morning first time. If I have to take like an hour and a half in the morning.
You're probably getting some heartburn overnight.
I am 100% getting heartburn overnight.
So here's what you do.
I didn't want to talk about it. And Mike just like, you probably got heartburn. Yes, I got heartburn at night.
So there is a, without getting too far, there is a nocturnal hydrochloric acid secretion pattern, and it will increase overnight. And so that's why a lot of people will get like early morning heartburn, or like they'll wake up with a metallic taste in their mouth. A lot of that is due to the heartburn overnight. So I'm telling you, here's what to do. This is not medical advice. It's just suggestion.
Mike,
Josh
you
is on
give
my
me
page.
so much medical advice. If I died, they would have a hard time finding all the things that Mike told me what to do. Like, so don't even worry about it.
So if you want to go after this, super simple. The easiest place to start is a Pepsid twice a day. You can take that for like 2 weeks, see if it'll heal your gastric lining and things calm down. If you want to go beyond that, again, that doesn't work for a lot of people. It's a Band-Aid. If you want to go beyond that and actually try to heal that mucosa itself, first place I would start is I would get some zinc carnosine. Zinc carnosine. It is a supplement. You take it twice a day, 75 milligrams twice a day. Great data on actually healing gastric ulcers. They've used it overseas in Japan for like 30 years. Why haven't we done it? I don't know. So I would do that twice a day for about 4 weeks. I have some patients that tell me, hey, I've been on omeprazole, Protonix, whatever it is for forever. The very first day I took this zinc carnosine, I didn't have any heartburn. Do you think it's a supplement? And I'm like, yeah, I know it's a supplement. The secondary benefit of zinc carnosine is that they've shown that it actually regulates that intestinal hyperpermeability or leaky gut that we talk about. And so you got to get a twofold benefit. You're not only healing the gastric lining, but you're also regulating that excess permeability. So I would start with zinc carnosine. The thing that you can take for like acute breakthrough episodes is I really like a product by Thorne called GI Relief. It's a combination of things like DGL, deglycerized licorice, marshmallow root, slippery elm, a lot of these like mucilaginous herbs. And so that's going to give you more of the acute kind of pillowy barrier on the gastric mucosa. It's 4 per day. If you're getting mainly like heartburn at night, you can take 4 with your last meal of the day and then take the zinc carnosine twice per day in the morning and then do it like mid-afternoon or with dinner. Those two together, I wouldn't be surprised in about a week if you start getting hungry and the nausea in the morning goes away. That's your telltale sign that the heartburn's getting better.
So can I just add that to my cart for full script? What
Yep.
is it called for Thorn? What is it called?
So for Thorne, it's called GI Relief. And for the other one, I like it. It's by a company by Integrative Therapeutics.
I
It's
just
called
found
zinc
it.
carnosine. That's
Yeah.
the cheapest one on full script. And the dose is 2 of those per day.
So I guess I'm adding that to my full script now.
We literally just need to get on these calls once a
So,
week and be like,
you know-
diagnose this.
You know when it does increase, Mike? It doesn't. I was literally sitting here and I'm like, well, I'm not going to tell him on purpose that I'm having heartburn at night. And Mike goes, yeah, heartburn at night. Yes.
Nausea
I
in the
literally was
morning.
like, I was trying to work my way around that. And you're like, probably having heartburn. Yes, I'm having heartburn.
Oh my
Nausea in the morning
gosh.
with low appetite is heartburn most of the time, or it's high cortisol, or a combination of both.
Well, I do notice that my heartburn issues that I have off and on are related to an increased amount of calories.
Mm-hmm.
So I will say that I probably need to go back to when you had me using digestive. Now that I'm at 3,500 calories a day, probably a good quick fix is back to those digestive enzymes you've had me taking before. That can help. So, it's work to get 500 carbohydrates and 3,500 calories in a day. Like that's work. Like there's nothing worse than 6 o'clock at night looking down and going, I have to do 200 carbohydrates between now and 8:30. Like what am I doing?
You might want to also elevate the head of your bed by like 3 or 4 inches. And that will help too, because you eat at 8:30, but even if you go to bed 2 or 3 hours later, it's still chewing through your digestive tract.
Yeah.
That just keeps it out of your esophagus. It just keeps it moving downward just a little bit, 2 to 3 inches, not much.
Hey, back full circle.
Yeah, we just totally diverted.
And that's okay because we started talking about
But
the insulin sensitivity thing, and we always have the conversations that due to my supplemental routine, I'm highly insulin sensitive. Like I can eat a ridiculous amount of carbs and not have a problem, and I'm highly insulin sensitive, and most people can't do that, right? And when people are like, "How many carbs do you eat?" 500. Well, how do you stay healthy? You're lean. I'm like, well, that's a further conversation we're gonna have that involves hormones. But if you're a female and you have PCOS, simple brain, Mike, this is 1 + 1 = 2. Okay, this is a simple brain, so you can be like, yeah, I wish it worked that way, but it doesn't. Can women start training to increase muscle mass? To improve insulin sensitivity? Can
You're
that
saying,
help?
can they?
Well, no, a woman who has PCOS.
Yeah.
Lifting weights and getting stronger and building muscle tissue, to me, is the best overall net positive for insulin sensitivity. So are we telling women with PCOS you need to hit the weight room?
I am.
Okay. You are. Yes. Yes. Mike.
But that's
now
like,
we go back to the
top
birth control. We
recommendation.
go back to the birth control and metformin. Most people are getting birth control and metformin, right? I recently had a conversation with a girl. She was working out and lightheaded. Next day, lightheaded. Workouts lightheaded. This is over the school year. And I said, "Hey, do you have low iron?" She's like, "Oh, I used to have low iron." And she's like, "I think I have low iron again." And I'm like, "Well, has things changed?" She's like, "Well, I got off birth control." And she's like, "I have a really bad time of the months."
Mm-hmm.
Like really bad. 16-year-old girl. And like, I always give a girl like a little kudos for admitting something like that to me. And then like, it's like they're talking to a dude. I'm like, "Oh, honey, like, what are things you can do?" So like, it's just, the birth control makes me feel bad. And then I get off it and I have really bad time of the months. And then I have low iron and like, I got to get an iron. And like, I was like, and I just said this in passing, I say, "Hey, talk to your parents about finding somebody to look deeper into that." Because while the easy answer is some iron pills and birth control, as you get older and want to become a mama, let's take care of that. I said, I would really recommend to really find a deep dive into what's causing some of those things
Yeah.
not to freak you out, but just say, "Hey, go to your mom and sit down with your mom and say, I really want to look deeper into this." She goes, "Yeah, I think I want to." And that's
That
the
was
best
like
way I can help somebody in that situation. Right.
100%. Like looking back on our conversation with Lisa that did all of the period tracking and stuff, I thought that was like such a cool message that she had. Is like, just do the deeper dive, like get to know your cycle, get to know your body as a female, because a lot of the time, I don't think as a young girl we know what's normal and what's not normal, right? When
Well, she talked about
when we
checking
start
the
menstruating.
consistency of the fluid inside your underwear. I'm like,
Yeah.
I'm like, is it getting awkward in here? Or is this like when she said, "Then you two connect and start talking about it," I'm like,
Yes.
I don't think I
You're
really
like, what
want to
are you
know. I
talking
don't want to
about? I
know the
know.
consistency of the fluid in Gray's underwear at all. No, I don't.
But I think that's like,
Yeah.
constantly trying to break the mold. I know, Mike, you do a great job of doing this, of like just reinforcing the idea that it may feel like it's normal, but it's not. Like it might be common, but it's not normal. So it might feel normal in your day to day, but it's not a normal thing that you should be experiencing.
Well, that's a tough thing. And I was having this conversation with myself in the kitchen yesterday. Me and myself, we're talking. We talk. I don't know. That's another. Is that normal? Do y'all have conversations with yourselves?
Oh,
I have
all
conversations
the
with myself
time.
all the
And
time.
it's better now that I have a dog, because now I can talk to him. But
I talk to my dog. I
myself.
can tell if my dog's having a bad day and if she's sad.
Yeah, me too.
Because the
Me
way
too.
she looks at me, like, "Oh, it's not having a good day." And in reality, she's just like, "Can you go to bed and leave me alone?"
You're pissing me off.
But I had a mild heart condition as a kid, diagnosed low cardiac myopathy and large heart. I take care of, make sure blood pressure, everything, good heart rate. Usually only ever feel it if I gain a lot of weight or lose a lot of weight in a short amount of time. That's weird. But I remember being in the kitchen and I was just kind of thinking like, I probably need to go, get my heart checked again. But it feels normal. And then I'm like, well, how do I know if it feels normal? How do I know if my heart and everything, I've always had the same heart. So how do I know if it's normal? That makes me kick back to girls in irregular periods, PCOS, the androgens. I mean, I think you'd know if you grew a face beard in a girl, right? I mean,
Yes.
you'd know if all of a sudden you're just like, I probably need to shave.
Yeah.
But PCOS, is that usually starting around when like a girl starts getting her period? Like, is that something that can build up over time? Do you always have it? Does it just magically show up? Or do most women that have had PCOS, have they shown symptoms from early on that it just becomes normal? They're just like, hey, this is just what it is.
A lot of times you will see it kind of as puberty starts to change and those hormones start to develop. The androgens may start to go up a little bit. But sometimes if it's just like really heavy cycles, you either get put on birth control or you get
Mhm.
told that you should take ibuprofen. Because the reason why is a lot of those PMS symptoms are due to elevated what are called prostaglandins, which are
Mhm.
basically like a inflammatory marker that the body sends out. So it's normal. It's part of the menstrual cycle. The issue is when a woman has really high PMS symptoms, it is often because they are making more pro-inflammatory, inflammatory causing prostaglandins and not enough anti-inflammatory prostaglandins. And so there's this imbalance in the types of prostaglandins. Now, ibuprofen will inhibit those more anti-inflammatory or those more pro-inflammatory prostaglandins. That's why a lot of people will tell you, hey, when I get a headache, Tylenol doesn't really work for me, but Advil does, ibuprofen does. That's because Tylenol is a pain reducer, whereas ibuprofen is a inflammation reducer. So they work differently. The thing to take away from that, though, is when you have these PMS abnormalities as a female, you can change those prostaglandin ratios with fish oils. And so a lot of times you have an omega-3 imbalance in these women.
Mhm.
So I will have
Mm.
them push up omegas really hard, 2 to 3 grams of omegas. So that is 2,000 to 3,000 milligrams of EPA and DHA daily. If you're looking at your store-bought fish oil, that might be 10 capsules a day. If you want a good quality fish oil, you might
Jeez,
take
Mike.
3 to 4. So that's
Be
the difference
burping
between
fish.
store-bought
Yeah.
and nutraceutical. If you do it with salmon alone, you will have to eat around 6 to 8 ounces of salmon 3 times per week. So you
I
have
do
to
that.
change the
Do you really?
prostaglandin ratios. And then there's another compound called leukotrienes, and those are affected by omega-3s too. But the takeaway is a lot of these women, if you want to start with a very, very low level intervention, it is pushing up omega-3s. I posted a study on
Mm.
Facebook about this, showing that I think it was 3 months of omega-3 intake at 2 grams led to a 40% reduction in PMS symptoms.
Mm.
Now, those same women, they checked them at 1 gram initially, and they did not have statistical significance of PMS reduction, meaning that it is dose dependent. So when people are like, I took this and it didn't work, it may not have been the compound. It may have been the fact that you weren't taking a physiologically relevant dosage to change the underlying symptoms. So that's the first thing. So it probably does show up somewhere along the onset of puberty and then throughout the young adult life. But a lot of times these people get stuck on birth control. They'll get told to take ibuprofen. They'll get told it's normal. And then they won't notice these very subtle androgenic symptoms.
Right.
Maybe where we see some darkening of the skin around the armpits, maybe the back of the neck. Maybe you're just starting to see like a little darkening of facial hair on the body, but not on the face. That's still an androgenic related pattern because that hair will sometimes be on the legs, general area of the chest, all these sort of things. And you don't think too much about it because you're not seeing it every day like the face. And so,
Mhm.
as such, a lot of times these women will go through life and maybe they won't find out until they're trying to have a baby. And then they're like, oh, you're infertile because you have PCOS. Or eventually somebody will do a workup once they get established with an OBGYN. And that's when they'll do a pelvic ultrasound, an intravaginal ultrasound. Oh, you've got multiple cysts. You probably have PCOS. And so this is where we can start to get into the diagnostic piece because one of the first things that will probably get run in nearly 99% of humans, you go for a physical, your doctor's going to check a fasting glucose. The tricky part with that fasting glucose, or they're going to check a glucose, whether or not it's fasting or not will be depending upon the provider and whether or not they're thinking about this, but it should be fasting at some point along the life of this human. And so if they check that it's abnormal, then they'll add on an A1C usually, or if the person's obese, they'll add on an A1C. The progression of changes is the first thing that becomes abnormal is fasting insulin, not fasting glucose. An elevated fasting insulin can date a fasting glucose elevation by over a decade. That's the first
Why?
thing that changes. So basically, when somebody's eating too many carbohydrates for too long, what happens is your pancreas, your beta cells start kicking out all this insulin to try to compensate. When there's too much insulin, the body downregulates insulin sensitivity at the receptor because there's too much stuff floating around. So the body says, all right, we've had enough of this. We're not going to keep accepting this insulin at the receptor. So what happens is the pancreas secretes more because your blood sugar stays too high for too long. So now as that pancreas is working, the
Mhm.
fasting insulin is elevated and it's going to stay elevated
Mhm.
chronically. more so after you eat, and then it will probably go down. But because your blood sugar is already chronically elevated, it's going to take longer for that blood sugar to go down. So you're going to secrete more insulin under the curve of that blood sugar. Over time, those beta cells will eventually start to lose function. When you start to lose function in the beta cells, that's when you're going to start to see A1C start to creep up. The number that you're looking for is greater than 5.6. Pre-diabetes starts at 5.7. So if you have an A1C that is 5.7 or higher, you have already started to lose beta cell function physiologically. So this is super relevant because if you're a young woman, you need to ask to have a fasting insulin on your blood draw. Many times people will not run it. I tell providers, please use AI to find the diagnosis codes to get these labs covered. It's a great way to find a way to get this data for your patients in an insurance model. You can put in nondescript HIPAA compliant information and find out what diagnosis code will get it covered for specific insurance providers. That's the first step. The second step is the patient can pay cash. It's about less than $20 to get a fasting insulin. It's super simple. But if your fasting insulin is elevated, a lot of times in conventional medicine, the range is 2 to 25. And so if you get a fasting insulin and it's like 18, 22, your doc's going to say, you're fine. There's no pathological problem here. The problem is data coming out of a 2018 study in premenopausal women. They looked at what level of fasting insulin is most closely correlated with the highest risk of something called metabolic syndrome. That's when you have high blood pressure, elevated triglycerides, low HDL, the good cholesterol. It's basically this cluster of symptoms that shows your body is not metabolically healthy. That's all it is. Medicine came up with a new name for multiple things that were happening simultaneously. But what level of fasting insulin correlated with the highest risk of metabolic syndrome? 7.8. Not 26, which is above the lab reference range. So the only reason why I'm harping on this so much is that number one, it doesn't get run. Number two, it's not expensive. Number three, the reference range is looking at the pathology of disease. It's not looking at early indicators of metabolic dysfunction. In general, you probably want that insulin to be single digits. Ideally, you probably want it to be less than 7 fasting. If it's not, then we got some work to do. But that's the number one thing you want to run because fasting insulin is going to go up first. Fasting blood sugar is going to go up second. A1C is going to go up third. So if you're waiting on your doctor to check your A1C, you could already be 10 years into a high fasting insulin, increasing that pancreatic beta cell exhaustion that we talked about, further exacerbating all of the insulin resistance that's already there. And we already talked about when insulin resistance is present, it increases sex hormone binding or decreases sex hormone binding globulin, which frees up more androgens. So you're going to get more androgenic symptoms. And when you have more androgens, you're further going to dysregulate menses. So now you're going to have, along with the androgens, the other thing to keep in mind is androgen hormones are anabolic. They are growth promoting. So androgenic hormones in and of themselves are very important on the pathogenesis of cyst development. So you can see how it's this big snowball. The insulin resistance leads to the decrease in sex hormone binding globulin, which leads to the increased free testosterone, which leads to the increased cyst formation, which leads to increased pain, which leads to increased cycle abnormalities, and so on and so forth. So continue.
Just going to, because you touched on this earlier, just for clarification, when you say someone that eats a lot of carbohydrates, what does that mean? Because I think people will kind of take that in two ways. Some women might say, oh my God, I eat so many carbohydrates. And it's like not a lot of carbohydrates whatsoever. And then some will be like, oh no, I actually eat a lot of carbohydrates. It's a majority of my diet. So what would you say is a percentage of a lot of carbohydrates?
For some women, they are very sensitive to changes in carbohydrate intake because of the influence of carbohydrates on the thyroid axis. Those women probably will need about 100 grams of carbs per day. That's what's shown in the literature. So that's kind of like a good baseline for most women. A lot of women, I shouldn't say a lot, some women, because somebody will say, well, I feel great on carnivore. Cool. There's always outliers. But a lot of women will feel better on at least a baseline level of carbs. So I would shoot for around 100, 150 grams of carbs, because there is this disordered eating piece, like you're getting to here, that there's definitely this idea of like, oh my gosh, I had a sweet potato. That's too many carbs. Not what I'm getting at. So that's kind of a good baseline measurement if you don't want to get more in the weeds. If you do want to get more in the weeds, you can buy a little continuous glucose monitor. It's about the size of a quarter. You can slap it on your arm. It's $75 to buy one over the counter. You don't need a prescription. You don't have to have diabetes. They're called Stella and Lingo are the two different ones that you can buy over the counter.
Lingo's the one I'm interested in getting. Yeah.
Yep. So one's from, I forget the manufacturer. I will tell you, I've done both the Dexcom G7 and the Freestyle Libre. The Dexcom G7 is light years better. So if you have the difference in the Libre and the Dexcom, and it's a little bit difference in price, I would encourage you to get the Dexcom. It's good just to wear it for 30 days and see, how does my body respond to certain foods? I will tell you, I'm not a diabetic. I don't have any blood sugar problems. But when I wore that CGM, one of the things that I found interesting was the more processed the carb source, which this makes sense, but the more processed the carb source, the higher the blood sugar fluctuation. The more chaotic the environment, the higher the blood sugar fluctuation. The most interesting piece of that was I had a huge bowl of ice cream with family with nothing else in the meal, and I was cruising right at like 101.
Isn't that crazy,
So
bro?
for me, the takeaway, I was like, well, cool, I can eat all the ice cream I want. I'm just kidding. But it was at least an interesting finding that in those environments, it may be more so related to what's going on around you than the food sometimes, but it may be how processed the carbohydrate is. The flip side would be if somebody's like, am I eating too many carbohydrates? If you're drinking liquid sugars and you're having alcohol daily or multiple times per week, the answer is probably yes. Those are two things that are almost non-negotiable with PCOS. You can't drink liquid sugars. You just cannot do it. Your blood glucose variability will be off the charts. And number two is alcohol in general. What the data shows is if you're having around one drink every once in a while, it's not going to increase inflammatory markers like CRP and some other inflammatory cytokines. If you're having multiple drinks multiple times per week, study just published this year shows that premenopausal women will have, I think it was a 1.2 to 1.4 times higher amount of circulating CRP from alcohol consumption alone, independent of other variables. So that's why I say, if you already have a higher baseline of inflammation, like we talked about genetically, influencing insulin resistance, you can't have alcohol routinely. You just can't. And you can't drink liquid sugars. That's that level of carbohydrates is just too much.
Mm-hmm.
It sounds to me, Mike, that a lot of this comes back to inflammation. I feel the more conversations we have is chronic inflammation. And I'm going to tell everybody, go to that YouTube channel. I think it's called After School. After School has a whole 20-minute video about food farming by Dr. Zach Bush that I showed in my class every year. And every time I show it, it starts a conversation of inflammation, the food.
Mm-hmm.
And he's not, if you ever talk to Zach Bush, he's a very holistic kind of like, I feel like he lives in Asheville kind of guy. And he talks about inflammation, disease, and he gets deeper into just how all of that causes just the mental health, our separation from nature. Mike, one of the greatest comments you ever said, and to me, that was impactful. The longer you separate yourself, I'm going to say it wrong, but I'm going to paraphrase it. The longer you separate yourself from nature, don't be surprised if the more unhealthy you become.
Yeah.
Right.
I think inflammation in general, what I see more and more is like it's a disconnect from yourself even.
Well, that's what Zach Bush talks about. Yeah, Zach Bush talks about, the psychological effects of inflammation and the things that add inflammation to our body is a disconnect from nature and who we are and what we are. And don't be surprised if you start having, he got deep into like identity issues and health and identity issues and wellness, right? And he got deep into, I don't know if I buy some of that. I understand what he's saying, right?
Mm-hmm.
But man, here we are talking about PCOS and we're talking about inflammation. Here we are, talking about something else on the podcast and we're talking about inflammation. And then, Mike, anytime you've talked to me about, hey, I have a client that has this, hey, look at some of the things that can help. They're the same things that would control inflammation: exercise, better sleep, better food quality, watch how much fake food gluten we put into our body, like all of that. It sounds to me that 70 to 80% of the issues people have that are not genetic issues, that aren't, aren't pathologies, right? You're not going to fix type 1 diabetic. You can make their life better, right? I mean, they're going to have genetic issues that if we can eat, exercise, sleep, eat better quality foods, connect with others. That's the one I always I even told Gray, I said, one of the things I always do is I early on in my life, I didn't look at the importance of human connection.
Yeah.
And that's just a personality thing because I don't get my fulfillment from that, right? That's not where it makes me tired. I need to go take a nap after, right? But when you have those things and you add those things into your life, don't be surprised if we start becoming less sick.
Mm-hmm.
Don't be surprised if these problems start going away in society, right? Don't be surprised if you sleep better, you connect better, you're happier, find more joy in certain things. Because, man, there's nothing. I mean, one of the greatest podcasts we've ever had was conversations around chronic pain.
Mm-hmm.
And if you find somebody that has something, and we'll stick to PCOS, you find a woman that has really debilitating PCOS, I mean, changes everything in their life. You don't think over time there's a psychological, emotional, mental strain that this wears on somebody, a female? Be in a room when a female's told, hey, I'm sorry, you and your husband cannot have children because of PCOS. You did not know that value has been there since you were 15 years old. Be in that room. I bet that's a crappy room to be in. Right? I mean, I almost got a little emotional when we talked to our lady. Who's one of my ladies that talked about the nutrition and fertility?
Which one?
The one in Colorado. The one in
Oh,
Colorado.
Deidre. Yeah.
Mike, at the end of our podcast, and she was talking about inflammation and infertility, and she went deep into inflammation. I mean, having women change what they wash their clothes with, what their candles are, toxicity, what their food, their toxins, the I mean, we've talked about that. What you wash your clothes with, the candles, and she's decreasing inflammation, and your body's becoming more fertile. Like they're having baby, which is at the very organic part. We're all meant to procreate. Like this, everything's built on just making more babies, right? But I asked her at the end of it, I said, and she got emotional. Like she goes, man, I haven't, she goes, it's been a long time since I've sat back and thought about this. And I go, has anybody ever named their kid Deidre? I said that to her. Because like I would have, if this was you and I had 3 babies, they'd be Deidre 1, Deidre 2. I'd name a boy Deidre. Right? Because I'm like, and she almost got a little bit emotional. I almost got a little emotional because I'm like, man, sitting with somebody that does that. But here we are sitting about, I mean, can you prevent, is PCOS an environment type thing? Can you really go back, if you really did a deep dive, could you go back to Pettinger's cats, bro? Can you go back to what mom did, what grandma did, what great grandma did, and then great grandma turned into great grandma, did this certain way, but then great grandma didn't have it, but grandma, and then but mom started changing lifestyle, and we started industrializing everything, and we started eating certain foods different, and now we're seeing an increase in PCOS. Can you look at Pettinger's cats type environment where you can go back and be like, hey, this is a generational issue that changed our genetic code, the genetic code. Look at when Jack Bush talks about like mental health and autism, you're just like, what? It's got to be. And you look at the spike. Would you put PCOS as one of those things that you're like, hey, this is one of those things. This is one of those things that we're seeing a spike in that is related to these environmental changes over time?
It's certainly possible. I think that the correlation of the incidence of PCOS and the production of hyperpalatable, hyperprocessed foods is certainly an interesting correlation. I don't know if it's causative, But when you're seeing the availability of these foods overlaid with the number of chemicals that are now in our environment, and I know we will get some flack from people who will say, well, the chemicals in our environment are perfectly safe because you have a kidney and a liver, and those process all the chemicals that you need and they keep you safe. And I will tell you that that viewpoint, which is commonly spread on social media, is 100% entirely false. Couple examples. Number one, the incidence of Parkinson's disease is 128% higher when you're 3 miles from a golf course. Number two, the incidence of Parkinson's disease is 500% higher in those who use the highest amount of, I think it's trichloroethylene. It's the most common additive used in dry cleaning. Number three, for example, this is one that is developing, but the incidence of Hodgkin's lymphoma with the amount of glyphosate an individual used. You can go look into the groundskeeper who was in California who was spraying this on the playgrounds and had a raging case of Hodgkin's lymphoma. And he was one of the first people to sue Bayer that makes glyphosate. Number four, you can also look into the incidence. What state in the United States has the highest incidence of cancer out of every state in the U.S.? Do you guys know?
Florida.
Michigan.
It's Iowa. Do you know what state has the highest incidence of glyphosate usage?
Corn.
Iowa.
Do you know what state has the largest nitrate removal of their wastewater treatment facility in the entire world? Iowa.
No
Nitrates
way.
are used as chemical
Mike.
fertilizers.
Oh my gosh.
So, example number four, you should look into the incidence. Example number five, I'm counting.
I don't care. Who cares?
Example five, you should look into the incidence of pediatric cancers relative to their distance from the strawberry fields that Driscoll has in California.
I was just reading about this.
38%, or I think it's 32%, one of the two, higher incidence of pediatric cancers in that elementary and middle school. Again, those are five simple examples I just thought of off the top of my head. You can also look into chemicals like paraquat and atrazine. Paraquat is commonly sprayed on pomegranates. Atrazine is sprayed on all kinds of fruits. There was a citrus farmer who's now actually trying to go after one of the, I can't remember if it's atrazine or paraquat, but he's trying to go after one of those chemical manufacturers because he was just diagnosed with a very rare form of cancer that is also commonly found in atrazine or paraquat usage. Again, those are just some simple examples that your environment 100% and the chemicals that you put on your skin every single day, especially as a female, your chemical load is significantly higher than a male's. The study, I think the number was somewhere in the upwards of 200 different chemicals that a female will put on her skin before she even leaves the house first thing in the morning. Now,
Oh, in my home for sure.
yeah, yeah,
Without a doubt.
yeah,
Yes.
exactly.
That number is listen, we affect that number in this room
So,
without a doubt.
all that being
Where's
said,
Aaron Brockovich, man? Where's Aaron Brockovich and all this?
right?
Where's
all
Aaron
that being
Brockovich and all
said,
this?
150 years ago, a large number of these chemicals were not available. They were not even manufactured. We're introducing thousands of chemicals into the environment yearly, and no one is testing those. We've talked about this. In Europe, the burden of evidence is on the producer to prove that they are safe. The burden of evidence is on the consumer to prove that they are harmful in America. It's entirely messed up, but that's the way that it is. And so with PCOS, another component of this is anything that is going to increase inflammation. Keep in mind, inflammation is not the problem. We've talked about this before on a podcast. Inflammation is the body's reaction to something to try and get you back to homeostasis.
Yes.
Simply taking an anti-inflammatory does not solve the problem. You can have increased inflammatory markers from an infection. If you take ibuprofen, it'll go down acutely and it'll come right back up because the body is using that inflammation to try and resolve issue. The problem is when you have chronic unchecked inflammation from a source you don't know about, it then proliferates and causes other pathological issues, namely insulin resistance. So with PCOS patients, you have to go inflammation hunting and inflammation killing. It doesn't matter the pathology. If there's an inflammatory component, you have to do that. What does that look like? This person needs a really good dental exam at least twice per year. Go to your dentist. Periodontitis, independent of any other etiology, any other driving factor, will increase inflammatory cytokines. We know that every time you floss your teeth, if you don't floss routinely, you will increase bacterial levels of certain compounds in the blood when you fragment them when you floss. You got to floss regularly. You got to go to the dentist. If you have a chronic low-level dental infection, you've got a recurrent root canal or something that hasn't been fixed yet, and you have PCOS, you have to get that addressed. If you haven't been checked for sleep apnea, the number one independent factor of the degree of sleep apnea severity is how insulin resistant someone is. This is why a fasting insulin matters so much for people. Please go get this test. Pay for it out of pocket if you need to. If you have an abnormal body weight, better yet, if you're a normal body weight human and you have PCOS, a quarter of individuals with sleep apnea are normal body weight. They have a normal neck circumference. That's 25% of humans. We already know that PCOS predisposes you to insulin resistance, and insulin resistance potentially affects the degree of sleep apnea in normal weight humans. It's on Up to Date. If you're a provider listening to this and you're like, I don't believe that, go on Up to Date. It's literally on the Bible reference for medical providers. So you have to check sleep apnea. You have to check hormones, because if this woman is going through her cycle between days 19 to 22, you need to check a progesterone to estrogen ratio. You need to check a DHEA to cortisol ratio. The first one tells you, is this person estrogen dominant? Do they have really heavy cycles and they can't clear estrogen? Are they lacking progesterone? And as such, they have anxiety, they can't fall asleep, and their cycle length is abnormal. The DHEA and cortisol ratio will tell you, is this person chronically inflamed, aka high cortisol, low DHEA, or is their system just ramped up both with cortisol and DHEA? That excess DHEA from the stress response becomes testosterone. Chronic stress will worsen PCOS because of the increased androgens through the mechanism of DHEA. Does that make sense? Are you guys tracking? So with these sort of people, that stress can be psychological. So you can worsen PCOS with, oh my gosh, my inbox will not stop overflowing and I have a 2-hour commute to work. Or it can be physiologic. So if you have recurrent infections, if you have recurrent UTIs, if you have BV, if you have whatever the thing is that you keep getting, those things will worsen the stress pathology, because the downstream of stress pathology in the body is inflammation. To resolve the stressor, but the inflammation is going to worsen the insulin sensitivity, and the stressor is going to drive increased DHEA production, because that's how your body balances inflammation. DHEA is helpful. It's like the cleanup crew after cortisol goes up. Cortisol is anti-inflammatory, so its job is to get the inflammation down. So DHEA comes on board, but if you have chronic stress, you're going to have chronic elevations in cortisol, and you're going to have chronic elevations in DHEA, which is DHEA is going to become testosterone. Now you're pushing that androgen side, and you're pushing the insulin side, and it's all happening at the same time. So people are like, geez, this is a huge ball of wax. Where do we even start with this? You get the labs, you rule out whatever's contributing to inflammation. If this human is not going to bed before midnight, you have to do that. I don't care what's on Instagram. I don't care what's on TikTok. The data shows that when you go to sleep at certain times of the night, you get different stages of sleep. You will get into more deep sleep in the first half of the night and more REM sleep in the second half of the night. Independent of what time you go to bed, you will not have the same level of deep and REM sleep. You can check this with an Oura, with a Whoop, meaning that if you're going to bed after midnight, you are skipping a large portion of deep sleep, which is highly restorative to the adrenal glands. And as such, it gets back to that DHEA cortisol piece that we just talked about. Big takeaway, you get labs, you have to go to bed before midnight. If your sleep sucks, please fix it. That does not mean medicine. That means talking about all the things that contribute to sleep: blood sugar abnormalities, excess cortisol, high dopamine. We can talk about a gazillion things. Please work with a provider who will work with you to fix this without more drugs. Drugs are not necessary. Drugs do not mimic normal sleep architecture. I will never stop saying this. I will never prescribe sleep medicine for someone who has not tried all the other things and cannot sleep. So you have to fix your sleep. The third thing is you have to get active. You have to. I don't care what you do. It doesn't have to be weightlifting. Weightlifting is the best option. But if you're like, I hate going to the gym, cool. Take up salsa dancing. Take up rock climbing. Take up mountain biking. You have to do something, because it turns on that glucose transporter that is only active with activity. Only active. It will never activate any other way. GLUT4. The next thing is you have to balance blood sugars. You have to. You cannot skip meals. You cannot snack on just carbohydrates alone. You have to eat mainly meals. If you want to snack, it's got to have a couple components of protein, fat, and fiber, PFF, that formula that we talk about all the time. Snacks and meals always have to have that. You cannot drink liquid sugars. I will say it over and over and over again. These are the big things. And then you have to get rid of those things in life that are going to be endocrine disruptors. You can't drink out of plastic bottles all the time. You can't use nonstick pans. I know these are the boring, non-essential things that people overlook all the time. But in the long run, over 50 years of your life, these chemicals accumulate. If you really want to go down the rabbit hole, there was a movie that was made about this, about the forever chemical. It's called Dark Waters. It was published maybe 5-6 years ago. It's about the attorney that represented the farmer that all of his livestock was killed from these PFOS and PFOAs that are dumped into the drinking water from 3M, the company that made the nonstick Teflon pan chemicals that prevents your food from sticking to the pan. These have a half-life of 600 years. You will never outlive these chemicals. They will be in your body for the rest of your life. Reduce your exposures. Again, we can go on and on and on. We've covered so many of these things on so many other podcasts, but those are the big ticket items that you have to do those things consistently every single day.
Good stuff.
Yeah, I tell you.
I feel like we stayed pretty on target.
We did a good job. We did a good
We
job.
did a great job.
Real quick, because somebody's going to ask me about this. I forgot to throw this in the midst of everything else. The data on supplements, because we talked about metformin, birth control, the data on supplements is this. In overweight populations, berberine probably works in overweight populations. There has not been a head-to-head control from comparison of berberine to metformin, but I have had some patients that want to do berberine instead of metformin. I'm okay with that. You probably get less diarrhea with the berberine instead of metformin. I always tell them I don't know if it'll work equally as well. In normal weight women, the data shows that inositol gives you normalization of menstrual cycles, the time of those cycles, normalization of ovulation, independent of body weight. That is not the case with overweight women. So that's a key differentiator for inositol versus berberine. Other things that can increase insulin sensitivity, vitamin D. If you have PCOS, you got to check your vitamin D. It's got to be over 50, non-negotiable. You might need 5,000, you might need 10,000, you might need 15,000 IUs per day. I don't know. Please do not be scared of vitamin D. If you're taking a lot and it doesn't go up, you also need magnesium. You got to take both of those as a cofactor for vitamin D. Omega-3s. We talked about these earlier. These increase insulin sensitivity. They also will regulate the menstrual cycle. Other things like curcumin, because of the anti-inflammatory piece, will help with insulin signaling. Please, if you have PCOS, please get on a really high quality multivitamin. This is not one a day. This is not Centrum Silver. I hate them both. You will not find a good quality multivitamin with all the nutrients in one capsule. Very unlikely. You need an adequate multivitamin, which has a good dose of selenium, has a good dose of chromium, it has a good dose of B6, B12. A lot of these things help with blood sugar regulation. If you are missing those nutrients, you will have issues with insulin insensitivity because of nutrient deficiency. Backfill those things first. Make sure the body has all the things it needs to work normally. You got to have a good multi. You can add those other things if you want, but I always start good multi, tons of fish oil, tons of fish in the diet, and then do all the other things.
Okay. Dude, we appreciate it, man. Thank you for coming on. If you're out there in the world, we'll have Mike on again. We have plenty of podcasts. We probably need to put together a list. We probably go through and find Mike's podcasts.
Definitely. Always a good idea.
15 or 20 of them, right? 15 of them. So, Mike, we appreciate it, man. Take your time out, and we'll talk soon.
Thanks, y'all.
All right, guys. We appreciate it.
I think we're still recording.
No, it should stop. No, something went wrong.
Stop.